Boy, you hear a lot about herniated discs, don't you? When I started with Dr. Hemwall, so here's a picture of Dr. Hemwall. I put that out today. I started with him in 1993, so I've been doing prolotherapy for over 30 years. The number one condition that we saw at Caring Medical was chronic low back pain. So when I started in practice, chronic low back pain was the number one thing that I saw. Then as people started jogging and doing more and more activities in the late 90s, early 2000s, I started seeing more knee pain. And now in the year 2023, or from here on out, the number one thing that causes chronic pain is a breakdown of the neck curve because of cell phones and computers. But there's still a lot of herniated discs. And the number one reason that discs herniate in the lower back or the neck is from slouching. Basically, with slouching, not only does the cervical curve get reversed, so the lumbar curve and the cervical curve are both lordotic when you slouch. So when you slouch, the cervical curve reverses and so does the lumbar. And when the ligaments are stretched, the bones move excessively, and that's what causes disc herniation. So if you ask Dr. Hauser what causes a lumbar disc herniation, it's when the ligaments give out and there's too much force on the disc, and then basically the annulus fibrosus, the surrounding of the disc, it basically breaks, and then nucleus pulposus, or the disc material, then starts going outside of the disc, and it can then go on a nerve and cause severe pain. Like even just about 30 minutes ago, one of our staff has a visitor, a really good friend that I know very well from Texas. So I went just to say hello to her, and sure enough, she was here for a disc herniation, a severe large disc herniation. And I would say that prolotherapy definitely plays a role in the resolution, not just of some of the pain of a disc herniation, but also to try to prevent the disc herniation from recurring. Like back in the 80s when I was in training, 1980s, I mean, low back surgeries were rampant. Like they were just taking out bone, discs, and all kinds of stuff. And in the end, it was a dismal failure. It was a dismal failure. Like if you just non-discriminately take out disc material or remove bone in the lower back or the neck, that makes the low back of the neck more prone to getting instability. And like I said at the get-go, instability is likely the cause of why discs herniate. You know, and we all know in Chicagoland, I just got back, I just did a trip up in Chicago. I was at a medical conference. So I ate at Al's Number One Beef. We had Pizzeria Uno. And then, of course, Brad and I, one of the nurses here, we ate at Ed DeBevick. So a shout out to all of our YouTube visitors from the Midwest, especially Chicago. Obviously, shoveling, anything when you bend and twist, the disc can pop because those movements are what stretch the ligaments. And if you stretch the annulus fibrosus or the outer surface of the disc too much, the disc herniates and it can then land on a nerve. And this is basically what you see from the side view, where you have a vertebrae, and then the disc goes posterior. So obviously, if I have really bad posture, you can even envision where the vertebrae go like this. That's going to stretch the ligaments here, then the disc pops out. And this is basically what can happen. And nerve pain is horrible. Like I had a disc problem in my neck, and on a scale of 0 to 10, the pain got to be like 100. It's horrible. And what we did at the end of this video is you'll see an interview with Brad, the very nurse that I said I went to Chicago with. He had an acute disc herniation, and he's going to tell his story of how he got it resolved. And I think he was back to doing pretty much most things and back to work and everything. And pretty much living a normal existence within 6 weeks. I mean, it's not going to be something that somebody can get over, in a week or two, but if you carefully rest and do the prolotherapy and other things that you need, and there are times where you got to get the inflammation off of the nerve, and you do have to take steroids to get a steroid shot. So steroids are good when there's bad inflammation. So the disc herniates, hits the nerve, that causes bad inflammation on the nerve, and if you get too much inflammation on a nerve, eventually you could cause injury to the nerve. So the reason to do steroid in some cases of disc herniation is you want to prevent any sort of long-term nerve problem. And there's various terms that doctors use for disc herniation. Typically when the disc protrudes, it prolapses, it extrudes, and sometimes when disc material extrudes into the spinal canal and the pain's unbelievable, you have to get the disc material out of there. So that would be an indication when surgery might be indicated. And again, this is just another way where even a protruded disc or prolapsed disc can cause nerve irritation. That nerve irritation causes pain, really severe pain down the leg. And the pain is especially bad when you're walking around, and it can be really bad even when you're sitting. So sometimes the person has to be at bed rest. And there's even disc herniations that go into the vertebral body. Those are called Schmerl's nodes. Those aren't nearly as severe as the disc herniations that pinch on the nerves in the spinal canal. This just explains with age, you can see that the amount of lumbar disc herniations keeps going up as we age. So you could say, well, why is that? Typically, right, the 20-year-olds are more active than the 60-year-olds. So why is it greater in the decade of 60 to 69 versus like 20 to 29 or 30 to 39? It's basically the same reason that tendon tears occur. So 97% of tendon tears occur in an already degenerated tendon, and disc herniations are more likely to occur when the disc is degenerated, and by degenerated it means that there's a decrease in disc cells or strength in that disc versus somebody who's younger. So somebody's shoveling and they're in their 60s, they're more likely to get a disc herniation than somebody who's shoveling in the 20s, because the disc is stronger, the person in the 20s versus somebody in the 60s. It's really interesting how many low back MRI reports have information like this on it. That never used to occur, but basically there's been lots of studies to show that many people who don't have pain have a disc herniation or abnormalities in their disc on the MRI. So the radiologists who do the reports just want to make sure that the clinician, the doctor who ordered the MRI, understands that an MRI finding by itself means very little as it relates to disc herniations. I would order an MRI when I thought somebody had severe disc herniation pinching on a nerve. So that's different than just somebody with low back pain. So MRIs have very little value typically when somebody just has moderate to a little low back pain. When somebody has a severe acute, meaning they were fine, then all of a sudden they have severe low back pain with leg pain radiating down, the MRI can show not just that there's a disc herniation, but if the disc herniation is pinching on a nerve. So what I'm going to do is just show some MRIs that show disc herniation. I just want to show right here, see right here. You can see where there's something outside of the disc and it's hitting these lines here. Those are the nerves. So right here, the disc herniation is hitting the nerve. And when that's really, really severe, sometimes doctors will recommend surgery. I would obviously recommend more conservative care. I put this one up here just to show the lumbar curve and the cervical curve are in the same direction. So if you said to me, what's the one thing that we can all prevent? It's just having proper posture, especially when we are using the computer. So you want the computer screen up, and ideally you want your chest up and you want your abdomen contracted and your neck muscles contracted. When that happens, you're restoring the lumbar lordotic curve and the cervical lordotic curve. When the cervical curve reverses or you lose the lordosis in the lumbar region, basically the ligaments are under stretch. And ligaments over a long period of time, if they stay stretched out, that's what leads often to instability. So the cause of lumbar disc herniations, the underlying cause is often lumbar instability. Now, somebody could say, oh, I was playing baseball, or I was shoveling, or I was doing gardening, then I got a disc herniation. Yeah, that was the straw that broke the camel's back, but already the person had lumbar instability, and that made them much more likely with gardening or shoveling or doing something, bending and twisting, to cause a lumbar disc herniation. So all of us, if we maintain the lumbar lordotic curve and the cervical lordotic curve, then you're much less likely when you do activities, you know, play soccer in the backyard or whatever, to get a disc herniation. And the friend that I saw here today, she basically said she woke up with it. You know, she woke up with it. So she didn't do anything. So what caused it in her? What, she rolled over? Like, you know how many times you and I have rolled over in bed? No, she had lumbar instability. And the way you document lumbar instability is by flexion extension lumbar x-rays. That's probably the best way to do it. And these are all the ligaments, the posterior ligament complex and the capsular ligament. Those are the ligaments that are stretched when we bend down or we have very poor posture when we're using the computer. This is just good to remember that the spine is mobile, but the ligaments that connect the bones, they're still supposed to be strong. When they lose their strength and the elasticity increases, and you would kind of know this is occurring in you because you have low-level, low back pain. Like, it's not normal. Like, I play golf, right? I'm in my golfing attire. So why does Dr. Hauser look like he's going to go play golf? Because this morning I hit some chips and I putted, so I did play a little bit of golf this morning. So anybody who does something like plays golf, runs, or every morning when you wake up you feel chronic low back pain, well, basically you have lumbar instability, and because of that the ligaments are stretched out. So when you get in a position where the ligaments stretch, that stimulates a reflex arc called the ligament muscular reflex, and the muscles tighten to limit the bony motion so you don't get a lumbar disc herniation, or you don't get it where the bones hit a nerve. So it's actually to protect the nervous system. So if you have low level, kind of, you've gotten used to it, low back pain, I'm telling you the underlying etiology of that normally is lumbar instability. The muscles are tightening as a protective mechanism, and what you need to do is get prolotherapy. Then this just explains that there's gapping in the facet joints there. So that's a normal disc, normal thickness. This has a flattened disc, and there's gapping of the facet joints. You can see that when you bend forward, the vertebrae are going to go like this, and where the vertebrae meet, that's called the facet joint, and there's ligaments around that called the capsular ligaments. Those are the main ligaments that become incompetent, damaged, stretched out when there's lumbar instability from poor posture or an injury. And this just explains that you get gapping when there's flexion, right? There's flexion, you get gapping of the facet joints, extension puts them together, and when you bend to the side, the opposite side is where the ligaments stretch out. Basically, spinal instability is what leads to herniated discs, pinched nerve. If the vertebrae moves too far in front of the other, that's called spondylolisthesis. Osteoarthritis of the spine is called spondylosis. Anyone who has a chiropractor and you have to go to the chiropractor a lot because your vertebral segments are slipping, that often is from instability. That would be the time to go get an evaluation by a prolotherapist, because if you constantly need adjustments or you have clicking, popping, grinding in your low back, well, popping, clicking, grinding of the low back is not normal. You know, like most people, they do a bunch of things. They play soccer, they do a bunch of things. They don't have popping, clicking, grinding in their low back. So if that's you, it means you have instability and you should get it checked out by an experienced prolotherapist. Obviously, people can get herniated discs in the thoracic spine. Happens much, much less. So think about it. Why would herniated discs occur so much less in the middle of the back than the lower back? You know, you could say, well, there's more force in the lower back. That's correct. But the ribs protect the thoracic spine. So the ribs give stability to the thoracic spine. So it's much less likely to get unstable than the lower back. This just explains that you can get disc herniations. You can get massive disc herniations in the thoracic spine as well. This explains that the disc to vertebral height ratio, the low ratio in the thoracic spine, is one reason that is less mobile than the lumbar or cervical spine, but also because they have the rib attachments. And then this just explains, like on a normal MRI, the discs are white because they're hydrated. You could see here where it's dark, that's a dehydrated disc. Remember I said that as you get older, you're more likely to get a disc herniation. So as you get older, the discs get more and more dehydrated, more degenerated, less cells, less strong, and those discs are more likely to get herniated. These are just activities that increase the pressure in the disc. Obviously, the greater the pressure, the more likely the disc is going to herniate. And what I wanted to especially note is that where it says bending forward is 150%. Basically, when you bend forward, it's a massive amounts of pressure on the disc, and that bending forward is normally the posture where you get a disc herniation. And this just explains the various motions, and you see there where somebody's standing, they're just standing and they're bending forward, and that just puts an enormous amount of pressure on the disc, and that is normally the posture that gives you a disc herniation. So this just explains the degenerative cascade. So it basically, somebody has poor posture, then it causes some ligament injury, the bones move excessively, then it's a progressive disorder. So once you get one ligament damaged, loose, or incompetent, the adjacent facet joint or ligaments become injured, and then the vertebral segments move too much. When they move too much, then obviously the discs between them are going to get injured. The force on the disc is going to get greater, and then eventually the disc becomes degenerated. The annulus fibrosus becomes weakened, and then you get the straw that breaks the camel's back. You're playing golf, you're bending down, you roll over in bed, and then boom, you get a herniated disc. When I first started 40 years ago, I mean, you just did bed rest, and it's unbelievable how many things get better when you just do bed rest. Now this is a normal disc. That's a severely degenerated disc. That's what it looks like. It's a progressive disorder. So once you have instability in the lower back, the adjacent segments are then going to likely become unstable. And they still do lumbar fusions, and sometimes you need to get a fusion. But the problem with fusion is you get adjacent segment disease where the L5-S1 is fused. Well, then all the motion has to occur at L4, L5, and then that segment gets degenerated, and sometimes they have to increase the fusion or extend the fusion. So a better option, if appropriate, I'd say, is prolotherapy. Prolotherapy is a treatment that causes the ligaments to thicken and tighten and is very good at resolving instability. Now, I put some slides up here which are very detailed, but if anybody wants to look at does conservative care work, you can see here where at 2-year follow-up, 83% had complete and sustained recovery when they just were treated conservatively. 10% of the people ended up with microdiscectomy. I've even had good friends who had microdiscectomy. I think it's better to try not to get a microdiscectomy or surgery. Microdiscectomy is where they just take out the disc material that's on the nerve and irritating the nerve. Some people, the way their lifestyle schedule is, their work schedule is, they can't wait the 6 weeks or whatever. They can't wait the 2 months. Like there's just too much going on, and those are typically the people that end up with a microdiscectomy. I personally think, I have a feeling, the people who don't get microdiscectomy and they just do conservative care, they let the body heal it, they get some prolotherapy, they do some physical therapy. I have a feeling those people long-term have better results. I can't prove that, but that's my sense in being in the regenerative field over 30 years. This is some more data. At 1 month, surgical patients did better, but results were the same at 12 months and 24 months for leg pain, low back pain, and functional assessment scales. So in summary, surgery, because they remove the disc material right away, often has better results short term, but long term, there's not really any difference from like at 1 year for people who didn't do surgery and those who did surgery. So that would be another reason to try not to get a surgery. So 10-year conservative care study on lumbar disc herniation. This is another one. Over 95.4% were either satisfied or extremely satisfied with just conservative results. And you could see where at 10 years on a scale of 0 to 10, the average person had a pain scale of a 1, which is basically nothing. And that was from Korea. There's other studies that show over time the volume of the herniated disc goes down. So meaning that at 10 years, the body reabsorbs that disc material that herniated. That's basically the bottom line. So the body has tremendous regenerative capacity. I would say it would be helpful and even preventative to get prolotherapy, because the underlying cause that led to the simple motion herniated the disc was ligamentous injury, and the treatment of ligamentous injury is prolotherapy. This is Danielle here doing the lower back, and you can see where she uses ultrasound, and you'll see basically the fluid going in. She's at the lumbosacral junction. You could see the needle going in, so she's guiding the needle. You see the bone there, so most of the injections are going to be around the facet joints. And you could see it's done very quickly. Every poke of the skin, there's 1 or 2 cc's of fluid injecting in there. You see it going in there. You see her going basically at L5-S1, L4, L5, L3, L4. Then she'll do the attachments of the gluteal muscles. A comprehensive treatment of the lower back also involves the sacroiliac joint. So now she's going around the sacroiliac joint. Yep, and the sacroiliac joint is very large, so you'll see her go up and down there. So sacroiliac joint, lumbar vertebrae. And most people do it without any sedation. We see people every 4 to 6 weeks. Many people come once a month for prolotherapy. The typical person for low back pain, herniated discs is anywhere from 3 to 6 visits of prolotherapy. We like to see people till 90% of their symptoms are resolved and they're basically back to normal activities. I'm going to interview somebody who works here, who's an integral part of the care here at the Hauser Neck Center, Brad Evans. And Brad, I thought you would, well, why don't you explain what you do at Caring Medical, what's your title, and then, what happened to you?
Yeah, so I'm an LPN here at Caring Medical. My primary job is to help Dr. Hauser with patient care. So I just help with the procedure itself. I try to ask the right questions to get an accurate history and make sure they're safe during any of the procedures, and and all kinds of other little tasks that relate to just helping patients move forward with their treatment plan.
And then what happened to you exactly, that obviously I'm interviewing you for?
Yeah, so I was picking up a sock out of the laundry bin, and all of a sudden I had horrible pain in my lower back. And thank God I work here, because I was able to keep a cool mind over, I had just intense, horrible muscle spasms along my spine where it took my breath away. I couldn't even talk. It was very shocking, and it almost made me into a weird laughter. I was so surprised at how awful this was. And so I had to call into work that day. Couldn't come in.
How long ago was that compared to today?
So that was about 4 months ago.
Okay, so 4 months ago.
Yeah. So 4 months ago, and then
the worst pain you ever had?
Worst pain I ever had. I mean, I've probably had comparable pain, but it was over and over and over again I kept having the pain. So anytime I moved at all, I had that horrible muscle spasm with that pain, and that lasted at the most extreme level for about 2 to 3 days, where any kind of movement.
You did bed rest?
Yeah, so obviously I called you, figured out what we should do, and then so I did strict bed rest for almost 3 weeks. It was bed rest or standing to get up to do.
We thought it was probably an acute disc herniation,
right.
Probably.
Right, exactly,
Okay.
Yep.
Okay.
So at first, before we knew the disc herniation, I tried to see if something maybe just slipped and I was severely out of joint.
Yeah.
So I saw a local chiropractor who, she did a great job. She tried to get me back in alignment. We took x-rays. But we both knew kind of by the end of it, there's probably a disc problem, which is what we thought from the beginning. So since right after that I was in so much pain, I called you for medication. We had to get on a steroid pack just to halt the pain from being so awful. And then we went to, next day, got in for an MRI of my lower back, which revealed L5-S1 disc herniation protruding to the left side on my nerve. After that, speaking with you, the plan was to stay on strict bed rest for a few weeks until I can kind of do some normal functions, and then come in for some prolotherapy.
Yeah, I think you and I, we had, obviously, you think a lot like me, so that's one of the things I admire about you. And I told you when I worked in the VA, a lot of people don't know that, so I worked for 4 years basically at Hines VA Medical Center in Chicagoland. And that was at a time period where it wasn't such a rush to get people out of the hospital. And there is a time where somebody has a medical illness like the flu or an acute disc herniation, where if you just let the body heal it,
Right.
it's unbelievable what the body can do. But we're all so quick to this is hurting a lot, so I'm going to get microdiscectomy, and the doctor's going to take out a lot of my disc.
Right.
So you may feel better temporarily, but is that really a good option long term? So we had these discussions about, you really trying to be at bed rest and just, describe kind of what happened, and then how long were you out before you tried to come back to work, or you came back to work?
Interestingly, it wasn't such an easy decision just to stay on bed rest, because you're kind of panicking. The pain is so much that I was like, if I didn't work at Caring Medical, I would have already been to the orthopedic. I would have been already in surgery, because it's severe debilitating thing where you start to think, am I disabled? You know, is it even repairable? And then even the thought of that it's not necessarily just a ligament problem, which is what we treat with Prolo primarily. It's a disc, you know, so you start to have these fears, but I said, no, you know, I got to take my doctor's advice. I help patients with this all the time. So I just got to, you know, stay with the advice. And then I also was very blessed to be able to see at my wife's boss at the time, who's a physical therapist, and she helped explain the McKenzie maneuvers, which were basically leaning in the opposite direction of the injury. So I was flexing when I herniated it. So then if I leaned back, I had relief.
Okay.
And so then I would practice these very gentle exercises. She was able to look at my MRI really briefly. And this really helped me kind of, you know, I'd say maybe get out of the red zone of feeling so terrible. And then it probably took about a week and a half to 2 weeks until I got my first prolotherapy to help resolve the immediate pain and to you know, start the stabilizing process. And then I tried to come back to work for one day around 3 weeks in, and halfway through I started getting numbness and tingling in my glutes and down my left leg, and I started walking funny, and so we knew it's not time yet, unfortunately. So then I had to stay off work for an additional about 2 weeks. And then after that, for almost a month and a half, 2 months, my wife had to drive me to work every day because I was actually unable to sit at all. So at work I could stand, or I could lay down. And so in the car I had to fully recline with my feet extended and roll under my back because I was totally unable to sit. So luckily now, it's been 4 months and I can sit really as much as I want. Sometimes I feel a little pressure, but I just think I'm on the right track to have full resolution.
How many prolos did you end up having?
4 treatments every 2 weeks.
Okay.
So total 4 treatments every 2 weeks. And then we're likely going to do another one, you know, in about a month or so.
What would you say, what did you learn through the process?
The biggest thing I learned for sure was empathy, to understand what my patients go through.
Okay.
Because to say you're in extreme pain is only so relatable until you're in extreme pain.
Yeah.
So patience, understanding when somebody feels anxiety or fear and uncertainty, and trying to understand that, you know, not everybody's so as privileged or as lucky or as blessed as I am to, you know as much as I do in those situations. So I think that's the first thing I learned. And then I also learned to just be patient and rational, to not take the mindset of fear and urgency, when sometimes you just need to think logically, pray, you know, and talk to your mentors on what you think is the best.
Was there anything that you had done in your past that you think might have loosened the ligaments or something of your lower back, like posture things or being kind of irresponsible with the way you moved, or was there anything, like looking in hindsight? Yeah,
absolutely. There's probably 2 greatest things. The most superior thing, in my opinion, is sitting, generally. Sitting and slouching.
Right.
You know, not just sitting, but also slouching, because, you know, all of us are bad at it. And almost everybody we know has back pain. And from a functional standpoint, it doesn't make much sense to me that a human is unable to lift something from the ground. I don't really blame any particular lifting as much as I do, why is everybody, you know, not everybody lifts, but almost everybody gets back pain. But that being said, I do think I probably had some ligament issues, and then I was also doing like powerlifting, trying to lift like heavy deadlifts.
Okay.
And there were times where I knew I kind of tweaked it with my form, went bad. But again, I feel like I was maybe susceptible to those tweaks because of the underlying issue, which is the curve in my back was becoming less lordotic. I was sitting all the time, likely contributing to ligament laxity fundamentally. So
yeah. So there's the global assessment of human disease, so years lived with disability. Headaches, number 1, you know, years lived with disability, meaning that headaches often occur in a young age, and then, you know, people live the rest of their life with them. Number 1 was low back pain. So in the whole world, like the
Yeah.
ears live with disability. And if you think about it, it's actually the same process. It's like, we're hunched in front of a computer. So you're losing the lordosis in your back, then you're losing the lordosis in your neck. And there's so many similarities in the physiology of the lower back. Like, obviously I have a pillow here, but so obviously people, it'd be good, so if somebody's like this, that I have the lordosis here, then I have the lordosis here. But once you go like this, once you go like that, you lose the lordosis, and that's, of course, is going to stretch the ligaments. So you're optimistic, and you're probably happy that you didn't end up having surgery of your lower back.
Yeah, I'm extremely optimistic, and at this point, I'm presuming a full recovery. Even at this point that I'm at, even if this is where I stopped, I feel like I'm pretty much able to do all the activity I want to do.
Okay.
Maybe I'd be limited from, powerlifting again,
Yeah.
but I do think that I'll make a full recovery, and yeah.
Pretty much it's what everybody would think. Like initially when people have a microdiscectomy, initially they often have quicker pain relief.
Yeah.
But really by 6 months, even a year, it's even, as far as like treating it conservatively versus surgery. So, if somebody can avoid a surgery, it's probably a good idea.
Right.
So, and then you were an excellent patient. Like, you actually listened. Like, sometimes in the office you don't listen. But no, but thanks for sharing your story.
Yeah, absolutely. And thank you, Dr. Hauser, for being there, for taking my call right away, and giving me the advice that you'd give yourself, because I knew that you would do that. So and I appreciate Caring Medical for taking care of me, giving me treatments, and for being patient as I couldn't come back to work for a while. So yeah, well, thank you.
Thank you.